Good afternoon. My name is Charlene McMann Seaman, and I'm here with Battling and Beating Cancer. And we're here today with Dr. Stephanie Gregory from Rush University Medical Center. And I wanted to welcome you today.
Thank you, Charlene. It's a pleasure to be here.
Wanted to talk about our new organization, Chicago Blood Cancer Foundation. And I wanted to talk to you today and see what you could tell me. What I'd like to find out is, of course, you're a dear friend and one of the best leading oncologists, hematologists in the country. And we wanted to talk to you today about, of course, you've been in this field for so long, and we want to talk to you about where we've been before, where we are now in the present, and in the future as far as where we're going with blood cancer research. And I know you specialize in lymphoma, and we want to talk to you about lymphoma and multiple myeloma today. So I wonder if you can give me kind of like a background of where we've been and what types of leaps and bounds we have made as far as cancer research.
Thank you. Thank you. You know, I think first of all, the important thing is to define what the blood cancers are. And you sort of mentioned that there are lymphomas, there are leukemias, and there are multiple myelomas. And your wonderful foundation is going to really address the needs of the lymphoma patients and the myeloma patients. Lymphoma is increasing in incidence, and I would say 20 years ago we had very few patients with lymphomas that were actually cured, except for the rare exception of the patients who had Hodgkin lymphoma. And the Hodgkin lymphoma is quite different from the non-Hodgkin lymphomas, which are really increasing in number. Where have we been? Where are we now, and where are we going is an excellent question. I think where we were until 1997 is that the only way we could address the treatment of, let's take the lymphomas first, is with radiation and chemotherapy. Surgery really has no role in the treatment of lymphomas. It is not a surgical disease at all. And so up until, as I said, 1997, the only thing we could offer patients was radiation therapy, and that usually did not cure the non-Hodgkin lymphomas patients because they had disease throughout the entire body, including the bone marrow. And you cannot radiate the bone marrow. You'll damage the blood cells, and patients will die from infection or bleeding. Chemotherapy, on the other hand, we started combining drugs and we started seeing better results, but the toxicities of those drugs were great. We had to deal now with patients, for example, who sometimes we combine radiation and chemotherapy. We had to deal now with secondary cancers that were coming down in patients that we cured with lymphoma because of the treatment they received. And when you combine radiation and chemotherapy, you get long-term side effects on the bone marrow and secondary cancers. So where are we now? From 1997 to the present, I would say we had the miracle of developing immune therapy. And immune therapy is actually not chemotherapy. It's not going in, hitting the patient over the head with a big hammer and destroying normal cells and abnormal cells. It's actually targeting the patient's cancer and asking the immune system to come in and help kill those cells. So it is less toxic. Immune therapy by itself today is not curing cancers, but for every cancer that immune therapy is being used, either alone or with chemotherapy, we're seeing longer and longer remissions and improved overall survivals. That's where we are now. What's coming are the new targeted therapies. We're refining the immune therapy, and I will mention the immune therapy that's been approved since 1997 is a drug called rituximab. Some oncologists call it vitamin R because it's used in almost every lymphoma that we see, except for T-cell lymphomas. And it is really added to most regimens today. Where we are going is we're trying to make a better rituximab. We're refining it. Rituxan was made in a mouse, it was humanized, and so there are some reactions to it. We're trying to refine that monoclonal antibody. We're trying to make it humanized so side effects will be less. The body's own immune system will be more effective in killing the cancer because we have a human monoclonal antibody. And some of the other new targeted therapies are actually looking at the whole signaling pathway in the cancer cell that makes that cell grow. And we've identified certain signals that we can now attack so the cell doesn't keep dividing and it dies. And so we're looking at many, many targeted therapies that are increasing the cell death. And that's referred to as increasing apoptosis, increasing cell death of the cancer cell. I think in a few years we're going to be talking not about chemotherapy so much, but perhaps combining immune therapy with some of these new targeted signaling agents and making cocktails of the new targeted therapies, hopefully with less toxicity.
Mm-hmm. What about vaccines? Because I know vaccines are, you know, the thing
Yes,
I know there's
yes.
some clinical trials going on with vaccines.
That's
so
right, Charlene. There were 3 major clinical trials in the lymphomas over the past 10 years. 3 companies actually, and vaccine therapy is actually taking a piece of the patient's lymphoma, in the laboratory identifying the specific fingerprint that makes that cancer specific to that patient. They may all have, say, for example, a follicular lymphoma, but every follicular lymphoma patient has sort of a different fingerprint. And they could actually, by taking part of the patient's lymphoma, make a specific vaccine to attack their specific lymphoma. Now, it took up to 6 months to make those vaccines, those personalized vaccines. So often patients would have to receive some chemotherapy before they received the vaccine therapy back, and reduce the tumor, and then we would maybe give them 6 months to a year of their own vaccine by injections, just like you give someone a vaccine. The studies, all 3 major vaccine trials today, have not demonstrated major efficacy in prolonging survival at this point. I'm not saying that vaccine therapy by any means is dead in the lymphomas. We're trying to refine it, look at it perhaps in a little different way, but as of today, there are no vaccine therapies that are approved or on the market.
Okay.
Which is a little sad.
Yeah.
It was millions of dollars,
Right.
many patients volunteering for those studies. And I must admit, I was involved in 2 of the 3 vaccine trials. We put about 20-some patients on those trials. And many of my patients are still having a very lasting and enduring remission. But you know, in clinical trials, the majority of the patients have to have enduring responses.
Right,
and so I think it works in some patients and perhaps doesn't work in others. And that's what we're refining right now.
Well, we have, the reason I asked too is because we had a friend who actually went into a vaccine trial with stage 4 melanoma.
Oh.
And it's in 9 years or something. He's doing fabulous.
That's wonderful.
So, yeah.
And actually, vaccine therapies are being continue to being looked at in other tumors. And I think they're certainly still promising things that I think we can hope for some of the vaccine therapy trials. Certain drugs are being developed for certain
clinical trials, and then you find they may be beneficial to another cancer.
That's a good question. So those trials are often called phase 1 trials, where patients may not have any other options of treatment. And so phase 1 trials are looking at a relatively new drug and trying to determine which cancers it really works well in. And so there are several drugs that they would put together lymphoma patients and breast cancer patients and lung cancer patients, and then they would detect a signal that maybe it didn't do anything in breast cancer, but they saw some responses in really patients who had failed everything else in lymphoma. So then they would take that new drug from a phase 1 to a phase 2 trial, and now they would use it only in lymphomas. The phase 1 trials are mainly for safety. Is it safe to give patients this drug, and what is the dose that we're going to use? And then if you see a signal in certain cancers, you take it into the phase 2 trials and you say, let's look at it only in lymphoma, because in the phase 1 trial it looked like we had a signal in lymphomas. And then they'll do a study mainly with lymphomas. And if it looks very promising, then we go into phase 3 trials where they'll compare that new drug with the standard of care and see, are they equal? Is one better than the other? And so that's how we're really developing our research today.
And it's so important, and I can't emphasize this so much, because we see people that go to the standard therapy with chemotherapy, radiation, or whatever, and they don't go into remission. And there are other things out there, like you said, the monoclonal antibodies that people aren't aware of, and they don't go into the trying to find out the clinical trials, and we try to emphasize that so much to people.
We need to do a better job in the United States
Mm-hmm.
on explaining to patients that a clinical trial does not mean that they're a guinea pig or that they're
Yes.
going to get a drug that's never been tried in a human before.
Mm-hmm.
All these drugs that we're using in clinical trials now have had many phase 1 trials. We know they're effective, and we will not take away standard of care. We're just hoping that we can add it to standard of care or do something better than standard of care. In the United States, only 3% of all patients go on clinical trials. If you look at Germany and France, they can accrue patients to clinical trials within a year, thousands of patients. It's an honor for a patient in Europe to go on a clinical trial. They know they'll get the best treatment. They know that they'll be followed more closely than if they were in the community or in an academic center getting routine treatment. We have to follow these patients meticulously. And personally, you get a lot more attention on the clinical trial than in just receiving what is standard of care.
Well, even because we deal with so many cancer patients, and they're at the end of their therapy. There isn't anything else, and we try to emphasize that. Look for a clinical trial, because that's where you're going to find the cures, because that's the research, and that's where we found a lot of the cures, for different types of diseases. So,
and many of the clinical trials, Charlene, close because we cannot accrue enough patients to them.
Yeah.
I already know at least 2 of the new monoclonal antibodies, where one for chronic lymphocytic leukemia and one for relapsed follicular lymphoma, that just could not accrue enough patients, and the company could not continue to afford to develop the drug.
Yeah. And I think it's just the awareness that people, like you said, they don't know. So
They don't know.
it's something where we try to get that out there too, and in when working with cancer patients. So it's really
Thank
we know
you.
we know so many people.
We are so thrilled at the New Chicago Blood Cancer Foundation that we thank you so much, because we need to try to keep our resources in our city, and we all have so much that we can offer and so much that we can do. But as you know, today the governmental funding is at an all-time low. I have some brilliant PhDs who just cannot get grants. They can't get funding, and that's sad.
And that's why we do a lot of lobbying to Congress and asking for funding, because the last time I checked, they're doing we pay basically a penny out of a dollar for research, cancer research. And how long are we going to talk about cancer? It's we've been going for decades, and
it's one little step at a time. I mean, people will say to me, when are we going to cure cancer? Cancer is not one disease. It's when are we going to cure the follicular lymphoma patient? When are we going to cure this kind of a patient with this kind of a cancer? And cancers today are so heterogeneous that even within the lymphomas we have 70, 80 different kinds.
Right. And that's what we run across to all the time. They'll say, well, what do you have? Well, I have cancer. Okay, well, what type of cancer? Lymphoma. What type of lymphoma? Because there's so many different types, and that makes so much difference with the treatments, with their survival, everything. So we started we started our new organization, Chicago Blood Cancer Foundation, and of course we did work with another foundation for many years and raised over $3 million in Chicago. And
kudos. And I know the work that you've done.
And the reason that I got into, and I think this, is because of my dear husband, who is now a 11.5 year survivor of non-Hodgkin's lymphoma. So,
and I believe he had a kind that was a very aggressive lymphoma,
yes,
from my understanding.
It was aggressive, and he actually had surgery, which is something that they don't normally do, because it was in his.
That's correct.
Yeah,
right.
it is on his heart and everything. But what we wanted to do, and again, I got up one day and I said to my husband, let's start our own organization and keep the funding in Chicago. We kind of went with the Werners, as you know, Michael and Laura Werner, and Scott and I sat down and we said, let's talk to them. So we did, and we decided to pick 3 great universities in Chicago to work with and get this off the ground. So we want to do a lot in Chicago to give you the opportunity of getting the research dollars, so you can develop more treatments for people who are suffering from these diseases.
I think what has been one of the hampering problems is that research sometimes is done in a vacuum. And I think that the major academic medical centers have sort of been elite in their own way. And I, for the first time in my life, which is wonderful, we are working with the other institutions in the city of Chicago. And I see this as one of the most wonderful things that can ever happen, because we may have something that we can do in one type of a lymphoma, but the University of Chicago may have the lab ability to have a PhD who can do some of the molecular work on this same lymphoma. And Northwestern University may be able to come up with a certain kind of a clinical trial, and Rush may be able to develop that even further. So we're going to work together, which is something we started doing a couple years ago. The academic centers in the city of Chicago are unique. We have something that the other major centers and major cities in the country have not been able to do, and that's talking to each other.
Right. And that, again, it's a competitive, it's competition. It is, you know, and that's what we think is just really tremendous, because we're excited about this to work, because our thing is we want to bring everybody together to make better treatments and
it's the only way it's going to happen.
Find a cure someday.
That's what's happened in Germany and France. They are proud to work together.
Right, right.
And the answers come out of these very large randomized trials. We need to do the same in the United States.
Let me get back to, you know, I know you can talk to me about stem cell transplants too, because those are a big part of, you know, getting somebody through remission and living a normal life. So if you can kind of cover that a little.
Yes. And the real question is there a role for stem cell transplant in the lymphomas? And the answer to that is absolutely yes. We know that the most aggressive curable lymphoma is called diffuse large B-cell lymphoma.
That's what my husband had. Right.
And so if that is not cured with a regimen called rituximab plus CHOP, which it isn't in a group of high-risk patients, if they relapse, they can still be cured with a autologous stem cell transplant. Now, an autologous stem cell transplant is not really the same as taking somebody else's bone marrow and putting it into you. It is actually better described as giving the patient high-dose chemotherapy that they couldn't otherwise tolerate, but they can tolerate it because we've taken some of their normal bone marrow out of their body. We froze it away. We now give them really high-dose chemotherapy to kill their cancer that has come back, and then we give them back, just like a blood transfusion, their stem cells that come from the bone marrow and the blood, and their bone marrow regrows, and you get red cells and white cells and platelets again within a couple of weeks, and that cures relapsed diffuse large B-cell lymphoma again in 40% or more of the patients. Now, we have to continue to do research, because some of the very high-risk patients, when they relapse, they don't respond to chemotherapy again, so they can go into a transplant situation. Transplant has a very important role in young people, I feel, who have the so-called indolent lymphoma, follicular lymphoma. And although it's usually not done, certainly frontline or even sometimes in the early relapse, if I have a young patient with follicular lymphoma, and remember I said most lymphomas occur at the age of 60 or older, I'm seeing 25-year-old and 30-year-olds with these lymphomas of older patients. You get a young patient and you say, oh, don't worry, you have a lymphoma, it's slow growing, you've got about 10 years to live. What would you say if you're 25 years old? 10 years to live? So we often will transplant those patients at their early relapse. If they've had some treatment, they're in remission only for a year or so, and they relapse again, there's a very important role for transplant in even the low-grade lymphomas. And there are some rarer lymphomas that certainly transplantation has cured some of those patients.
Now, again, when you ask a doctor this, I always find to determine cure, because again, you know, it's a very slippery slope, because when you say cure, you think, okay, cure, but you are seeing some cures in some of the lymphomas that were not there many years ago.
So some of the The most common lymphoma, the diffuse large B-cell lymphoma, we feel very confident in saying that we are curing 50% or more of those patients with the regimen called R-CHOP. If those patients relapse, the other 30 or 40% who aren't cured with R-CHOP, if they relapse, if their disease comes back, stem cell transplant will cure another about 30 or 40%. So we are curing patients. There definitely, no question. The low-grade lymphoma, follicular lymphoma, which patients have always, I get up and I've talked for 20 years, this is a non-curable cancer, but you can live for 10 years with it. Well, I'm beginning to say, you know, we always said this was non-curable. We're seeing cures. And I have some colleagues who feel that with the newer immune therapies and with earlier transplant in some of these patients, we are seeing cures also in the follicular lymphoma, which is supposed to be non-curable. The more aggressive lymphomas, which are rare but occur in young people, something called a lymphoblastic lymphoma, a Burkitt's lymphoma, if you don't treat it, they can die within weeks. But if you treat it with a very aggressive chemotherapy and you add immunotherapy to that, we are curing some of those patients also. So we are curing. Lymphomas are one of the most curable cancers out there, and especially Hodgkin lymphoma, which we haven't talked much about. But we're curing up to almost 90% of the patients with Hodgkin lymphoma.
Yeah, it's funny because not funny, but when Scott was diagnosed, when we heard he had aggressive, we thought, oh, that's terrible. But really, it was not terrible. It was the better one to have. As far as you also do a lot of work with multiple myeloma.
Yes.
So I was wondering if you can kind of, because I know people don't quite understand when they say leukemia, it's the blood and the lymph nodes, lymph system, and then it's the bone marrow. So maybe you can just different.
Right. So lymphomas are cancers primarily of what we call the immune system, which are the lymph nodes, and they follow the bloodstream. So the lymph nodes are like an extra artery or vein, and they are a chain of little nodules all throughout the entire body. And when you get a cancer that's called a lymphoma, it's those lymph nodes that enlarge. Because the lymph nodes are so close to the bone marrow and the lymph circulates through the bone marrow is often involved in lymphomas. Leukemias will start not so much in the lymph nodes, but actually in the bone marrow. And most patients who present with leukemia have a very high white count. That's not true all the time, so you don't see that often with lymphoma. You don't get a lot of very abnormal blood counts usually, and certainly not often do you get a very high white count. So that's leukemia. And leukemia means white blood. The white blood cells actually, when leukemia was first described, there were so many white blood cells in the red blood that it made the red blood almost look white, and that's leukemia, white blood. Myeloma is a different blood cancer that is a cancer also of the immune system, of the most mature lymphocyte called the plasma cell. And the plasma cell makes antibodies to fight all of our infections. And so you have an abnormal production of these plasma cells in multiple myeloma. They produce abnormal antibodies called immunoglobulins, and those proteins that are the immunoglobulins attack the bone marrow, causing anemia. They attack the bone, breaking down the bone, causing holes in bones, so you have painful bone lesions. And the protein can damage the kidney, so you have kidney problems. And so we often talk about multiple myeloma patients needing treatment when they fulfill the CRAB criteria. And the CRAB criteria means if they have a very high calcium level because the calcium is being released from their bones because the bones have been damaged. The R stands for renal or kidney damage caused by the abnormal cells and abnormal protein. So if they have kidney damage, you treat these patients. The A is anemia. The abnormal cells in the bone marrow crowd out the normal blood cells, so patients don't make normal red cells. So the A is anemia. And the B part of CRAB is bone disease, if they have a lot of holes in their bones. So if you have a myeloma patient, you always have to evaluate not only the blood, the bone marrow, but the bones, the kidneys, the calcium level. And if you have abnormalities in those, you treat, and we've had so many newer treatments for multiple myeloma, it's amazing. The standard of care for multiple myeloma is some chemotherapy regimens, but not the toxic chemotherapy that we had years ago. Many, many new agents today have been developed for multiple myeloma that don't affect the blood cells as bad as some of the chemotherapy drugs did. And then if you can get some kind of a response with these newer drugs, we often refer patients to stem cell transplant. It is probably still considered the standard of care for multiple myeloma, if you're up to the age of 70, to have at least a bone marrow transplant using your own bone marrow. Now, there may still be some myeloma cells in the bone marrow, but we've treated the patient that we get down to low enough numbers of plasma cells that if you transplant them back and they get a few cancer cells, their disease may not come back for a long time. But actually with multiple myeloma, we often do 2 transplants within 6 months of each other, and that's called tandem transplants. And so there have been major advances in the transplant of multiple myeloma, and now they're talking about maintenance treatment with some of the newer drugs after transplant, and some of these newer drugs are marvelously discovered drugs. There are drugs called lenalidomide and bortezomib, very effective in multiple myeloma.
Now, are those chemo? Are those
you know,
they're
we don't like to exactly use the word chemotherapy drugs. They're new classes of drugs, actually. They attack certain processes in the cell that, again, make that cancer cell grow. For example, lenalidomide actually attacks some of the proteins produced by cancer cells that make the cells grow. So this new drug, lenalidomide, that is a pill, actually suppresses some of these, what we call cytokines, or proteins produced by the cancer cell, so the cancer cell can't grow as rapidly. And the cancer cell also interacts a lot with the microenvironment of the body, the blood vessels and the stromal cells, the supporting cells of the bone marrow. And lenalidomide kills off some of the blood vessels, so that the cancer cells can't get a blood supply. So very effective new agents. Exciting.
Yeah,
exciting.
Very exciting. I know you have made leaps and bounds in the past probably 10 years. As far
I think so, and even 5 years.
Yeah, I know even Rituxan wasn't available when Scott went through his treatment.
That's
he just
right.
had CHOP. So, well, I really appreciate you taking your time today. And
no, I thank you.
No,
I thank
we
for
thank
all
you.
the work that you and Scott and the Werners are doing. We appreciate it.
Yeah,
thank you.
we're just looking to make leaps and bounds here in Chicago, and we want to get funding for research so we can find better treatments for people and possibly cure for some of the other diseases that lymphomas and that we cannot find.
Right.
So at this point, but thank you so much, Dr.
Oh, thank you,
Dr.
Charlene.
Gregory.
I love Stephanie.
I know it's hard for me to say Stephanie. I'm on camera here, so I have to say, I have to say Dr. Stephanie Gregory today. So, but thank you so much. And that's about it for today. We're wrapping up, and we had a wonderful visit with Dr. Gregory here today. And thank you again. We'll see you soon.